Starting, all attendees are in listen-only mode.
Hello, folks. This is Dr. Arvind Kanchi from Bangalore. We are starting our ECNF Everyday Case Series, Cases in Nephrology webinar series from the ISN Academy. And today we have Dr. Srijit Parmeshwaran, who will speak on the levels of proteinuria in nephrotic syndrome and its relation to protein intake. We will get to that in a moment. I have a couple of housekeeping announcements and a big announcement to make. The big announcement is that the Football World Cup has started. The Nephrology World Cup is ongoing. I request you folks to join the Nephrology World Cup. As you see on your screen there, you can see that we are in the process of playing a game called the Nephrology World Cup. And this is a game that's available to you folks, all nephrologists all over the world, people following us on Twitter. You can look at it on Twitter and Facebook and play the game. 32 participating countries who are participating in the World Cup football are also participating in the Nephro World Cup, and you can choose the literature from one of these countries, three of these countries for the top three, and the rounds as you speak. You can look at this through Twitter or Facebook and play. Please play. There are plenty of prizes to be won, including textbooks and the ISN Academy membership. So it's plenty of fun and something that you can learn along the way. That's about that, and let's get back to another couple of points as far as the housekeeping points go, and that is that we will have a couple of polls during the talk. We will also have questions from you, the audience. These questions can be asked by either typing it out, which is something that you can do at any time during the lecture, and I'll have a look at the questions and ask them of Srijit at some point in time. The other thing that you could do is physically speak. For that, you have to raise your hand and show your hand, and those items are present on the top right corner of your tab or phone or on the laptop. As you can see, the box for typing questions is present just below the polls, questions asked, and also you have the hand raised that you can see in the attendees section of the laptop sidebar. You can see it on the top right corner of your phone or tab if you have that, and if you're joining us through that. Now, let's move on to the topic at hand, and the topic at hand is levels of proteinuria and nephrotic syndrome and its relation to protein intake. An interesting topic, I must admit, and I'm sure Srijit will tell you a lot about it. A couple of points that obviously we are looking for is, does it matter in children versus adults? Because children, we tend to give a high protein intake. The pediatricians use between 1.5 to 2 gram per kg per day as an intake. Can't do that in adults. Does it matter if the disease is different? Does it matter if minimal change is causing the proteinuria? Does it matter if membranous or FSGS is causing the nephrotic syndrome? That's an interesting point that I suspect that we'll be looking at. And thirdly, we will be looking at something that I guess Srijit himself has studied in JIPMER Pondicherry, and he has looked at obviously how proteinuria and protein intake are interrelated. So that's something that he'll be speaking on. Fourthly, what about animal protein and vegetable protein or vegetarian protein? Does that make a difference? So these are interesting points, and that is something that's going to come up in his talk. Before we go on, let me introduce Dr. Srijit Parmeshwaran. He probably needs no introduction. After his MBBS and MD, he did his DM nephrology from the PGIMER Chandigarh, and from there he went back to JIPMER Pondicherry. There was, I suspect, no nephrologist at that time, and in 2009, when Srijit joined Pondicherry, he basically single-handedly set up the nephrology unit in Pondicherry and got things going. He has written many papers, research papers, 43 of them, book chapters authored, 6 of them. He's on the editorial board of journals. He has administrative capacity as the nodal officer of the NOTO, member secretary of the JIPMER, diseased donor transplantation, and so on and so forth. Srijit Parmeshwaran is the head of department of nephrology in JIPMER, Pondicherry. Over to you, Srijit. Let me share your screen. Yes, Srijit, go ahead.
So, good evening, everyone, and thank you, Dr. Aravind, for that fantastic introduction, and also for asking me to present this particular topic in Easy Nephro session. So this basically, this is not exactly a lecture. This is basically a study we did. In fact, it was a DM dissertation by Dr. Rajesh, whose name is there along with mine. So I'll be briefly discussing about the hypoalbuminemia and protein intake in protein in a couple of slides. There will be a couple of questions. Then I'll go about presenting to you the study we did, which will cover most of the topics already mentioned by Dr. Arvind. So that is all what I'm planning to do today. So let's go ahead with the presentation. So we all know that diet is an important thing for patients with kidney disease, and for us as nephrologists to know, because not only in the context of nephrotic syndrome, be it CKD, the signs and symptoms and the complications of kidney disease are significantly influenced by the diet the patients take and the diet we prescribe. And we also know that the clinical outcomes can also be altered by dietary interventions, be it protein, be it phosphorus, be it potassium, or even fluid intake, and of course the salt intake. This applies very well to nephrotic syndrome also, where the primary pathology is probably proteinuria, which results in hypoalbuminemia, and then there is dyslipidemia, edema, fluid overload. So all those things, a dietary intervention has significant role in addressing all these issues in nephrotic syndrome as well. We know that hypoalbuminemia is central to the other abnormalities we see in nephrotic syndrome, which it results from two mechanisms. One is obviously there is a urine loss, and the hepatic albumin synthesis is unable to compensate for this urinary loss of protein, which brings us a couple of issues which are not really very clear from the existing literature. For example, if you look at the urinary albumin loss in nephrotic syndrome, and if you take say for example a patient on peritoneal dialysis who also, we know that there is protein loss which may be as high as 10 or 12 gram per day. It is found that on an average the serum albumin level is 1 gram lower in people with nephrotic syndrome compared to those with an equivalent amount of, say, the nephrotic syndrome patient is losing 10 gram in urine. If you take a PD patient who loses 10 gram in the peritoneal fluid, the serum albumin level is higher in the PD patient, which there is some proposal or hypothesis that this may be due to absorption and catabolism in the proximal convoluted tubule. So actually what we are measuring in the urine which comes out is less than what is filtered and loss in which enters the PCT. There is some difference of opinion on this anyway. And we also know that the increased hepatic synthesis which happens in nephrotic syndrome is insufficient to compensate for the protein loss which is happening in nephrotic syndrome. And this has been partly attributed to the inflammatory state in nephrotic syndrome. And there are studies which have shown elevated levels of TNF and interleukin 1 suppresses hepatic albumin synthesis. So this brings us to the interesting, it's a clinically significant question which almost every other patient will be asking us, and we ourselves need to be asking how much protein should these patients be taking, patients with nephrotic syndrome. Should they take normal protein as they are taking even they run nephrotic syndrome, or should be they be taking, anyway the liver hepatic synthesis is unable to compensate for the protein loss, so can we replace it? For example, patient has 10 gram protein, why don't we give, say, what the normal requirement, 1 gram per kg per day plus this 10 gram? Is it okay to do that, or shall we give more to compensate for this increased loss and inadequate synthesis from the liver? Or is it also possible that if we restrict protein intake, the proteinuria may actually come down, and there may be an improvement in the serum albumin level? So this will so we'll go into the first poll as of now. Piero, can you go ahead with the first poll? Yeah, so the poll is open for all of you. The question is, how much daily protein intake do you recommend in a patient with nephrotic syndrome? The first option is high protein intake, 1.2 to 1.4 gram, normal protein intake, 0.8 to 1.2 gram, or low protein, which is 0.6 to 0.8, or very low protein, less than 0.6 gram per kg per day. What do you recommend to your patients? Yeah, so we have a significant number of people voting. 50% as of now has voted for normal protein, 30% for low protein intake, and 20% says uh, high protein intake. 78% have voted, and I think there's another 10 seconds remaining. Yeah, so I think we have the poll results now. Yeah, 81 people have voted, and 50% says that they will recommend normal protein. 23 and 27% says high protein, 23%, and low protein 27, very low protein 0. Okay. Yeah, so I would agree with this thing. So going on, high protein intake. If we give high protein diet, even though theoretically it may compensate for the protein loss, what is observed is that the fractional rate of albumin catabolism increases if you increase protein intake. So actually, in patients, the serum albumin level goes down if you give a high protein diet. So that's definitely not something we want. So high protein diet is not something which is good for people who are nephrotic, because it is observed that if you do that, the albumin levels actually worsens. Low protein diet, as we know, has some effect on reducing protein excretion, and but it has also been observed that it inhibits hepatic protein synthesis. So this probably balances out, and there are studies which actually people have studied in starting from the 80s and 90s, and most of the studies have observed that practically doesn't change the albumin levels. If you low protein intake, it's not that the protein albumin will increase, serum albumin will increase. Usually looks like the reduction in protein excretion is balanced out by an inhibition of hepatic protein synthesis. So but a low protein intake may benefit rate of kidney disease progression, which applies in those people with CKD or reduced GFR, but may not be as useful as we think in patients with nephrotic syndrome. So as a general thing, the safety of, there is another concern is that if you significantly restrict protein, there were studies where protein intake was restricted below 0.6 gram per kg, and there is some concern that such people may, especially if it is sustained for longer time, may develop malnutrition. And as such, the current status from literature, what I understand is that the safety of low protein diet is not proven. So there is no benefit as such, and in some patients there is some concern of producing malnutrition. So as a policy, what is usually done is to recommend normal protein intake, and that's what 50% of you voted also. So this, with this background, we will I'll be giving you a couple of case scenarios that will tell you why we actually go to do this study in JIPMER. So let's go to the cases. This is a 15-year-old. By the way, the study what we did were all adults above 18 years. Even though I have used a couple of cases to highlight the issue. So the first case was a 15-year-old lady. She came to us. These cases are pretty old, 6-7 years old, in 2010-11. This girl was symptomatic for an year. She had an episode of generalized edema, which was diagnosed to be nephrotic syndrome elsewhere, and she was not biopsied but treated with prednisolone, which is usual. She was given 1 milligram per kg per day for 6 weeks, and she went into remission. Subsequently, the steroid was tapered over 8 weeks or so, and then she was off steroids. She did well for many months, and then the edema recurred approximately after a year, and that's when she came to us. The first two reports are from the first episode. The first one and two, three and four are the reports during the episode when she came to us. You can see that proteinuria was 3 plus by dipstick. Patient had persistent hypoalbuminemia. There are no reports where after the remission in between. Albumin was 1.8, 1.9. The proteinuria, if you see, originally was 1.9 gram per day, and then 2.3. At presentation, it was zero point 0.5 for 571 milligram, and then repeated it was 1.1. She had hyperlipidemia at 551 total cholesterol. We did a biopsy which showed FSGS. She was treated with prednisolone. So this is a 15-year-old girl who had history consistent with nephrotic syndrome, responding to prednisolone earlier, relapsed after a year, had hypoalbuminemia, proteinuria, which is less than 3.5 gram, had hyperlipidemia, had edema, biopsy showing FSGS, no evidence of secondary glomerular disease, and responded to prednisolone, and she went into remission within 4 weeks, and subsequently the steroid was tapered off. The point I wanted to make is that this patient at any point of time, she didn't have the nephrotic range proteinuria. So we'll go on to the next case. This is a 21-year-old lady. Again, she had edema for about 2 months, and then she was initially treated by physicians, and then she was referred to us. She didn't have any hypertension. She had her body weight was only 35, so she was underweight. She was 21 years at that point of time. If you look at the proteinuria, she had 3 plus and then 2 plus. She had persistent hypoalbuminemia. The urine protein was always 0.8, 0.7 gram, and she had hyperlipidemia. The third one, the 220 of total cholesterol, was when she was already on atorvastatin. She underwent kidney biopsy and showed membranous nephropathy. That time this was in 2011, and we were not doing PLA receptor antibodies at that point of time, so we don't have that. But she didn't have any other features of either on IF or workup for lupus was negative, so she was considered primary membranous nephropathy. And she, without waiting, that's what we usually do in patients who are severely nephrotic, hypoalbuminemic. Without waiting too long, we do put them on modified Ponticelli. So this patient was put on modified Ponticelli, and she defaulted after the first month of treatment. She came back after another 2 months. This time she came because she had a gross swelling of her left lower limb, and the compression ultrasound revealed some probability DVT. She was put on warfarin, and at that point of time, the serum albumin was 1.5 gram, and proteinuria was 550 milligram, and she was restarted on modified Ponticelli regimen. She attained remission over next for 5 months, and by the end of 6 months, she didn't have proteinuria, and the serum albumin had recovered, but then the DVT persisted. So there are numerous cases like this, and these cases will tell you why we did this study. As we all know, the definition of nephrotic syndrome, the central part of definition is that patient should have proteinuria of more than 3.5 gram per 1.73 meter square body surface area per day. And especially in say people with membranous GN, you know that the level of proteinuria is actually used for management decision. For example, when a patient comes with membranous, if you put the patient on conservative management, usually we do it in some patients. Like there are some patients who already come with complications like DVT or rheumatoid embolism, and then we give them immunosuppressant straight away. So there, actually, you are supposed to take a decision based on the level of proteinuria and the reduction in proteinuria or lack of it over a period of time. But then what to do if the patient never had proteinuria and patient has frank nephrotic state, velocity matters, and has complications like the other patient who had DVT, even though she didn't have significant proteinuria, if you technically. So this situation is not unusual in our place, where we largely cater to it's not a very it's not a big city. It is adjacent districts are all agrarian, so it's a basically rural population. So we do a lot of patients who are clinically nephrotic and who have biopsy documented glomerular disease, primary and secondary and all of them are subnephrotic levels of proteinuria, or good number of them are subnephrotic level of proteinuria. So we thought we should probably do a proper study on this. And this is how we went about this. This was a dissertation done by Rajesh. I was his guide. All we included all consecutive adult patients. So this is only adults. Pediatric people were not included. Over a period of approximately 2 years. We excluded patients with secondary glomerular disease. So all those lupus were out. Impaired GFR defined as less than 60. Even if it was AKI, all those patients were excluded. Those people who are on AC inhibitors, ARB, those who had malignancy, active urinary infection, pregnancy, severe hypertension, heart disease or liver disease, and those people who were on steroids or any other form of immunosuppression, when they presented to us, were all excluded. We collected 24 hours urine protein and we estimated proteinuria by two techniques. I'll come to this later on. One was the turbidimetry, where the usual sulfosalicylic acid technique, and then we also did by a dye binding technique, which was the pyroglycerol technique. We also looked at the oxidative markers, because the biochemistry professor who was involved in the study has significant interest in oxidative stress and inflammation. So, interleukin 6, HSCRP, malonylaldehyde, and protein carbonyl levels, all those things were also done, and we tried to correlate with the proteinuria as well as serum albumin levels. We also wanted to estimate the protein intake. The method we used were not perfect, but I think this is the most practical things which we can do. So we did one calculated protein intake from the diary, where the patients were asked to write down for 3 days what exactly they took and the quantity. And the ICMR guidelines are available now. It gives you the a nutritional content of almost all Indian food items, including the South Indian ones like idli, dosa, sambar, chutney, all those things. It gives, if you take one katori of sambar, how much protein it has, how much calorie it has. So we calculated. This is one way we used with the help of a dietitian. And the second thing, we did a estimated protein intake from the urine, urea, nitrogen, using this formula which you are seeing on the screen. Using for this, you collect 24 hours urine, you calculate the urine, urea, nitrogen, and then use this formula to calculate the protein intake. So what basically we did is collected demographic data, estimated the protein, that we did by two techniques. Then we estimated as well as calculated the protein intake in these patients. We had 62 patients, primary glomerular disease alone, and 27 were females. Mean age was 41.8. The weight was 55. So they were not really severely malnourished. They were okayish sort of patients. Serum albumin, all of them had hypoalbuminemia. So the mean albumin was 2 plus minus 0.2. So hypoalbuminemia was a universal phenomenon in our patient. Proteinuria, by two techniques, they correlated well, and it was around 2.8, 2.9 plus minus 1. They all had hyperlipidemia. We did check the HbA1c again for some. We had done some previous studies on this. The calculated and estimated protein intake were pretty low, as you can see, and the inflammatory markers were actually high compared to normal population reference values. If you look at, then we looked at also the etiological spectrum based on the histology. 13 patients didn't have biopsy for some reason. The most common was FSGS, followed by idiopathic membranous nephropathy. Like, this is without PLA receptor antibody, so this is otherwise we have made a diagnosis of idiopathic membranous nephropathy. Minimal change, and there were few MPGN. So the MPGN again, that time, this is not based on EM. So only thing, it was light microscopy and IF features of MPGN, and secondary diseases like viral hepatitis C and lupus ruled out. That's all what I would say about that MPGN also. And there was no difference. We didn't observe any difference. Even the numbers, if you look at the absolute numbers of each etiology is small, but then there was no difference with regard to the histology, the level of proteinuria. We compared both new and relapse because we included those cases who were lapses also. 33 were new cases out of the 62 and 29 were lapses. Relapsing cases where they were not on immunosuppression for at least 3 months or longer. And if you see the proteinuria levels were actually lower in the relapse group compared to the new cases, and we have hypothesis. We don't really know exactly what is the reason. We have suggested some reason why this difference is there if compared to new and relapsed cases. So, summarizing the results, proteinuria was in nephrotic range, that is more than 3.5 gram, even after adjusting for body surface area, in only 9 patients out of 62. Okay, very small number had the actual nephrotic range proteinuria. So, if you go by proteinuria, none of them were nephrotic. Average protein intake was 0.6 gram per kg per day. So that this is not because we advised protein restriction. This is their usual normal diet. It is not because of we don't advise diet restriction at all for protein. And hypoalbuminemia was universally observed in all patients in this study. Inflammatory and oxidative markers were high compared to normal subjects. We didn't have controls in this group, but then we had data from studies which the biochemistry department had done, but they were not statistically really significant. And the proteinuria levels in relapsed subjects were lower. Could be because of they probably come to us within the presentation to us from the onset of symptoms is probably shorter. We don't have data on that. We are assuming here. Other reason is that maybe because the average number of relapses was 3. There were some people who had more number of relapses. So it's possible that they were malnourished also. We don't know. We don't really know what is the reason why the proteinuria was lower in them. So conclusions from whatever data we have is that the level of proteinuria in 85% of adults with nephrotic syndrome from biopsy proven primary glomerular disease was less than 3.5. So only 15% of patients with primary glomerular disease and clinical nephrotic syndrome had actually nephrotic range proteinuria, and they do not actually meet technically the diagnostic criteria for nephrotic syndrome. And we believe that low dietary protein intake may account for this law. There may be other factors also, but one factor is probably low dietary protein intake, which is inherent in their dietary habits, not because of imposed or prescribed low dietary protein intake. And I think the message out of this thing is that the diet and nutritional status of the patient should be taken into consideration for making a diagnosis of nephrotic proteinuria. This will be relevant when studies are done on nephrotic syndrome, because when we do studies, people can object to saying that actually none of your patients were nephrotic. So I would like to address few questions which where we ourselves asked, and when we try to present this data at conferences and other fora, the first thing was, was the urine collection really correct, or are you really sure whether the technique of protein estimation was, was there something wrong with the protein estimation? That is one common question. I would say almost everyone asked that. We ourselves asked it to our biochemistry people. Are you sure that the way you are estimating protein is correct? So that is the reason was suggested by the biochemistry department. We use 2 different techniques, and you are seeing that the 2 different techniques actually showed a significant correlation. So probably it is nothing to do with the technique. And urine collection was obviously a good number of them actually was collected when they were admitted, and we also estimated the creatinine in the urine, and we don't believe that it was wrong collection which resulted in low protein. Significantly, the previous 2 case scenario I presented, both of them were inpatients when the protein 24 hours collection was done, so that cannot be really wrong. So other question is there a coexistent malabsorption or are they already malnourished? I don't think we can classify them as really malnourished, because if you see the mean weight is 55, our people are not very tall, so their BMI are actually normal. It's true that some of them had edema, so the weight actually is with edema. It may be actually the lean body weight may be lower. Malabsorption, we really don't know. None of them. We have actually not evaluated them for malabsorption, but I would think, I don't know, maybe we should. There may be a component of malabsorption because of gross anasarca or something. Other question is, are they all vegetarians, and is it because of no, they don't take meat? So that again is not really the case. Technically, they are all not really vegetarians. Majority of our patients do claim to be non-vegetarians, where they do take egg, fish, and meat. But then what we have observed is that that intake is quite limited. They take non-vegetarian once in a week or so, and their protein intake on an average is pretty low. So not essentially because of vegetarians, but I think it has to do with the quantity of protein they take. They have largely rice-based diet, and they don't take too much of meat or fish or egg. So quantity rather than being vegetarian or vegetable diet, vegetable protein or animal protein the absolute amount may have something to do with the low levels of proteinuria. So this brings us to another interesting question: is the source of dietary protein important, like whether it's animal origin or plant origin? So can we have the second poll at this point of time? Is Piero still there? Yeah, the second poll is open. So is the source of dietary protein important? The option A is yes, animal protein is better. B is plant derived protein is better. No, doesn't make any difference. And this question I'm asking in not only in the context of nephrotic syndrome, you can assume it in general with regard to kidney disease. So majority of the people seems to be going for 44% as of now have gone for plant derived protein is better. 33% with animal protein, and 22% believes it doesn't make any difference. We have another 10 seconds before closing the poll. Yeah, so I think we have the poll results. 40% thinks plant-derived protein is better. 35% animal protein is better, and 25% thinks it doesn't make any difference. Yeah, so there is some, I think there is some literature on this. This is primarily in the context of chronic kidney disease, where protein from plant sources reduce proteinuria. When you give the same amount of protein, say 0.8 gram, reduction in proteinuria is probably more with plant sources. There is slower progression of CKD. There are some studies, I won't say they're absolutely conclusive things, but and some of them are expected, like for example, lower phosphorus intake, which animal protein is rich in phosphorus intake, the lower endogenous generation of acid, so there may be less of acidosis when you have protein from plant sources as the predominant source. And so there is a nice review on this topic in the in up to date. So maybe you should all refer to that one also. And there is some literature saying that soy-based diet, where there is high content of branched amino acid, arginine, proline, and glutamate, etc. If it is soy-based, it actually do not worsen proteinuria even if you give significant amount of protein supplement. So it appears that the source of protein does make a difference, and plant-based protein may actually be good in the context of chronic kidney disease, not necessarily nephrotic syndrome, and not when we are trying to supplement more protein. Yeah. So that's all what I wanted to present today. That's what we have observed in our study on proteinuria in our patients with nephrotic syndrome. Once again, thank you, Dr. Arvind and Piero, for this opportunity to present our data. We are ready to publish this, and I am sure this will have reminded me of this data lying with us, and most likely will get published soon. I'm open for questions. Thank you.
Thank you, Srijit. That was an excellent talk, and that was an excellent study that you've done. And it's very meaningful to note that most of our patients don't take as much protein as we think they do. The average protein intake, you say, is 0.67, which is really low, but that's where we are. We will go on to some questions raised by the group. I'm just looking at the question panel, and I have Shaktivel Venu who has raised his hand. People, if you want to ask questions, you can either type it out or you can raise your hand on the software there, right top corner of your phone, or in the attendees panel, you can raise your hand so that I can see and unmute you so that you can ask questions. Shaktivel Venu, I'm going to unmute you and you can unmute yourself to take control and ask a question. Shaktivel Venu. Do we have anything from you?
Actually, I'm unable to read those questions. Somebody has.
Not a problem. I'm going to read them out to you because I'm just waiting for these
Sure.
people here. Because I can't, I'm going to the questions that have been asked by Malvinder Parmar, who is better known as @WittyKidney on Twitter.
Yeah.
And he makes a couple of statements. Basically, he says that he thinks that the protein intake should not be restricted in these patients, and that should be the main message. I guess you already said that, Srijit.
I would agree with that.
Then he also asks, did you correlate proteinuria degree of kidney function in relapsed patients? If GFR is low, proteinuria may be lower.
Yeah, so we excluded those patients who had GFR less than 60, so that none of our patients had low GFR. One of the exclusion criteria was GFR less than 60. So we had only those people who had GFR more than 60 in our study.
Okay. He makes another comment. It's not lower phosphate intake, but poor phosphate absorption with plant-based proteins. And this is what he feels happens.
Yeah, that's also true because of I remember reading something about the phytates in the plant binding the phosphorus and preventing it from getting absorbed. I think that what he's saying is probably correct. It may have similar amount of phosphorus, but there are some phytates in the plant protein, and it binds the phosphorus, preventing it from. It acts as natural phosphate binders, I think. Yeah, that's true. I think it's true.
Fair enough. Srijit, I have a question myself. High protein diet obviously leads to a fractional excretion of protein increase in the urine. On the other hand, if you look at children who are nephrotic, by and large, pediatricians ask them to take a diet between 1.5 to 2.5 grams of protein per day, per kg per day, whereas in adults, we tend to give a normal protein intake rather than a high protein intake. Why is that?
No, like I don't know. Growing children do need a higher protein intake. I don't know whether they should be. This actually applies in children also. Most of the studies actually are from children. There are some studies from 80s and 90s where they have actually looked at the impact of various levels of protein intake and on serum albumin as well as the total albumin pool. And what I believe from whatever I have seen in literature is that none of them recommends high protein intake. In fact, the question is whether to give normal protein or restrict protein. Children by per se will need higher protein intake because they are growing. It's not that they need 1 gram. So they need higher protein, and I don't think they should be given higher than what is recommended for children. Because there are no studies saying that they should get a higher protein, and if there are some pediatric nephrologists here, they can correct me if I am wrong.
Fair enough. Professor Vijay Kher is with us in the audience, and he's raised his hand. Prof. Kher, I have already unmuted you. You have self-muted, so you need to unmute yourself if you want to ask the question. Professor Kher, I have unmuted you. You are self-muted. You'll have to look for the unmute button on your software. Usually the right top corner of your software if you are on a phone. Yeah, you're coming in. Yeah, you're on.
Okay, you can
Yep.
hear me?
Absolutely.
Yeah. Yes, Richard, that was very good.
Thank you,
I must say that did you have creatinine estimation in your 24 hours urine collection?
Yeah, we did that. Even I didn't know
And
that.
you found that the estimation, the collection of the urine from that estimation was appropriate.
Yeah, it was appropriate.
Yeah, so then at least because you were discussing that there was one question raised whether the collection of urine was appropriate or not in your discussion, and I think then that question is taken care of, basically that your collection was appropriate. It was only probably related to the poor protein intake that these patients probably had lower protein excretion. And just because many of our patients, and that is true, I think in all the Indian population that I see, malnutrition is a problem with chronic kidney disease, malnutrition is a problem in nephrotic patients, and that happens all across because our protein intake, whether it is non-vegetarian or it is vegetarian, remains poor, remains poor. Would you agree with that or not?
Yeah, I would agree with that.
Yeah, the other question I have is that although we would say that we should give these patients normal amounts of protein because there isn't any evidence, at least in the literature. There may be some evidence to suggest that, but by and large, the evidence is that do not modify proteins in these patients. You can give them normal amounts of protein, and they remain reasonably well with normal amounts of protein. But to say that plant proteins may be better, I think the evidence in the literature in favor of plants is poor, and whether it would be in patients who are extremely poor otherwise also, and in intake of food and all that, and the quality of that protein in the plant food is going to be poor. So I am not sure whether I would necessarily recommend in our patients that they should be taking plant fruits preferred over non-vegetarian foods. So I will leave it to the choice of the people. If they can have non-vegetarian food and proteins, I would probably recommend non-vegetarian proteins in these patients, despite very tangy kind of an evidence in the literature in favor of the plant proteins. What is your comment on that?
Yeah, thank you for the comments. Actually, two things regarding the plant protein. I don't think that whatever literature is there is in the context of nephrotic syndrome. So, if we are planning to supplement 1 gram of protein and in a nephrotic patient, I think it's probably better to give them high quality protein like animal protein rather than giving plant protein, because we are not concerned about the acidosis or any other things like that. So whatever the literature I quoted is in the context of chronic kidney disease, where we are actually trying to restrict protein intake, and we are trying to limit the consequences of protein intake in them. I would I am maybe confusion was created because I presented a literature here in the context of nephrotic syndrome. This is not really in the context of nephrotic syndrome. In the context of nephrotic syndrome, probably it doesn't make any difference, and this may be actually better. If you want to give 1 gram proteinuria, it may be 1 gram of protein intake. It may be better to give it as predominantly animal origin, egg or meat-based protein. The second one actually regarding the question regarding the protein estimation. What I meant was we had actually originally in 2011 we had compiled some data. It was done by an MBBS student, and we had presented in a couple of conferences. And I was referring to that when we presented that data, where we had only one method of estimation. And at that point, people were asking whether they were suggesting maybe there was something wrong with the collection, there was something wrong with the protein estimation. We learned from that, and when we did this current project, we addressed those. That's what I wanted to. That's what I want. That is the point I wanted to make. These were objections raised when we did the preliminary pilot sort of study by an MBBS student.
Arvind, can I ask another question, or you have other questions? Then I can maybe ask it later if there is time.
Please go ahead. No problem at all.
Okay. Srijit, one suggestion I have is that this study doesn't prove that protein intake has an impact on proteinuria. At least from this study, you can't make that suggestion.
Yeah. Correct.
Now, what I would suggest is that if you can continue maybe another study, then I think different protein intakes in subgroup of patients, and then looking at what happens to the proteinuria subsequently in those patients, maybe the better way of establishing that protein intake has definitely an impact on degree of proteinuria. Would you agree with that, or you feel that this would be sufficient
Yeah,
evidence?
actually, but we had thought about that, but I felt was had some practical issues because we usually don't only some of them are membranous and we put them on ACE inhibitors ARB. So unless we will have to delay therapeutic interventions either in the form of immunosuppressive treatment or ACE inhibitors ARB. Unless we withhold that, that sort of a because short time, say 1 week or 2 weeks, I don't know whether changing the protein intake over a week or so will make significant difference. If we have to do it over a longer duration, we had discussed that, and I thought it actually brings in ethical issues where people can say that we have delayed treatment for the nephrotic state in adults because usually we put them on something. If not, even if it is membranous, we will put them on at least ACE inhibitors ARB. Those can also reduce the proteinuria. So I was not really sure how to design that without having these ethical issues of delaying.
Yeah, I think in clinical studies this may be difficult, but has someone done it in the experimental, say in rats or rabbits or somewhere else? Is there any evidence? You may have read this kind of data anywhere. I'm not aware. I haven't done that, but I thought that maybe you would have read.
There are some studies in small number. Actually, they have done in children abroad. There are studies where they have prescribed different levels of protein intake. There were small numbers, 8 patients, 9 patients, like that. But I think, given the regulatory environment here, I doubt we'll be able to do it. Maybe we can do it in animals models. Maybe it will be much more easier.
Yes.
Yeah.
Thank you, Srijit.
Yeah.
Thank you, Arvind.
Dr. Arvind, are you still there?
Yeah, I'm back here. Sorry. Thank you, Prof. Kerr. I had muted myself. And I have another question. Prasad Srinivasan says, why was 24-hour urine protein used and why not albumin excretion rate?
Yeah, so we wanted to do 24 hours. Anyway, we had to do for the urea as well. Doing albumin excretion rate alone was not sufficient. So the study required 24 hours collection anyway. And a good number of them were actually admitted. So it was not inconvenient to do that. Doing albumin excretion rate alone would have prevented us from doing the urea nitrogen estimation. So we wanted 24 hours. That's why it was 24 hours collection.
Fair enough. Does anybody else have any questions? I see Shaktivel Venu raising his hand. I have unmuted you. Do you want to unmute yourself and ask a question or type out a question, Shaktivel? Haven't got a response from him, and if that is the case, and if there are no further questions, it is my duty to thank Dr. Srijit Parmeshwaran for an excellent presentation of his study from JIPMER Pondicherry. I'd like to thank Piero for hosting us from the ISN Academy, and I'd like to thank you all attendees for attending and making this an interesting discussion. Thank you all, and bye-bye.
Thank you, Dr. Arvind. Thank you, everyone.
Thanks.